Hello, everyone. In this video lecture, we're going to be talking about ICD-10 PCS procedures for the circulatory system. And this is a rather complicated set of procedures. This has several different things that we do. We do monitoring, measurement, we do cardiac caths, and we do other things as well. With measurement and monitoring, these fall into tables 4A0 through 4B0. Cardiac catheterizations are done to gain access to the heart for either diagnostic or therapeutic procedures. A diagnostic cardiac cath is basically a measurement procedure. We're running a cath to obtain sampling, pressure readings, and so on to measure heart function. Most of the time, these are done on the left side of the heart. You can see these in table 12.1 of your text. We have other diagnostic procedures. These include coronary angiograms. These are imaging studies of the left side or the right side of the heart that will show whether a patient has any endocarditis, any valve lesions, if you will. The coronary arteriograms detect obstructions in the coronary arteries. And the ventriculography measures stroke volume and the ejection fraction in the heart's ventricles. In other words, it's a measure of how much volume the heart can pump in its present state. Imaging is used to perform the coronary angiograms, the arteriograms, and the ventriculograms using fluoroscopy. The main term that you would use in the PCS index is fluoroscopy with the different subterms of artery, coronary, and so on. And you can look at table 12.2 for fluoroscopy studies. And the contrast material is low osmolar. There are therapeutic procedures that we do as well. One of these ones that we commonly refer to are the PTCAs, the percutaneous transluminal coronary angioplasties. Basically, this is a way of going into the coronary artery and opening up the vessel. We may put a stent in, and these stents sometimes will help keep the coronary artery open, elude medicine, and so on. The objective is to dilate. So the main term in the PCS index is dilation. And then the subterm, what are we dilating? The artery. What artery? The coronary artery or the bypass graft. Many times patients who have coronary artery bypass surgery will eventually need a bypass graft. You can see these in table 12.3. If the stent is placed, and again, the stents can be placed either in the native coronary artery or in the bypass graft, but if it's placed following the dilation, the device will be an intraluminal device. In other words, it's inside the coronary artery. The CABG, it's commonly referred to, isn't a type of vegetable. It's a coronary artery bypass graft. And there are two types usually. Aortic coronary brings blood directly from the aorta into the obstructive artery using a segment of the saphenous veins. We can also use the internal mammary artery. And basically, we use this internal mammary artery to bring blood from the subclavian artery to the occluded coronary artery and bypass the occlusion. The root operation is a bypass, and the body part values are the coronary artery. If a saphenous vein is used, it's considered a device, and it's an autologous vein tissue type of device. If an internal mammary artery is used, it is not considered a device as it's not detached. We're not removing it as we would a saphenous vein from the leg and reattaching it. Right. So take a close look at table 12.4 for the choices to code these bypass procedures. Cardiac pacemakers are a little bit complicated, and this is a procedure where you have to read the procedure note carefully to make sure you get everything correct. The pacemakers basically have three main components, if you will. They have the pulse generator that generates a power source, the pacing lead, which carries the stimulating electricity to the stimulating electrode, and then the electrode itself, which is the metal portion of the lead that comes in contact with the heart. So these three main components. There are different types of pacemakers, not one size fits all. We have a single chamber that uses a single lead that goes in the right atrium or right ventricle. We have a dual chamber that uses two leads that go in both the atrium and the ventricle. And then we have a rate responsive pacemaker that has a pacing rate modality determined by different variables. And then we have a cardiac resynchronization pacemaker that's without a defibrillator that performs ventricular pacing of the heart. So it's important to read what the procedure note says, and it will tell you whether it's a dual chamber, single chamber, and so on. Coding of pacemakers requires multiple codes, and you can see this in figure 12.4. So in this example, a dual pacemaker is going to require three codes. Why three codes? Because we need one for the insertion of the lead into the right atrium. We need another for the insertion of the lead into the right ventricle. And then we need a third for the implementation of the generator into the chest. And for all these things, since we're putting something in, it's an insertion. We also have the defibrillators. These are sometimes called AICDs. And these are a type of pacemaker, a special one, if you will, that treats patients with recurring dysrhythmias. And it's an electrical device with a pulse generator and the three leads. The generator is planted in the subcutaneous tissue of the chest, and one lead goes in the right ventricle, one lead goes in the right atrium, and the third goes on the pericardium. These defibrillator procedures are coded similar to a pacemaker. The device value, of course, is going to be different for the AICD. It will be a cardiac lead defibrillator. The root operation, however, will be the same. It will still be an insertion. And for both the pacemakers and the ICDs, you can find those codes in tables 02H and 0JH for the code construction. And that's all I have for you. We'll see you online. Please stop by office hours or email me if you have any questions about this material. Bye now.